Welcome back, coders. Let's just jump right in, shall we? We are officially at part 93 of our 100-part CPC exam series, and today we're unlocking the secrets of HCPCS Level 2 coding. Now, before we dive into the anatomy of these codes, make sure to like, share, and subscribe to Decode Healthcare with Harshal. Seriously, it helps us keep this massive exam prep series going.
So picture this. You're looking at a single medical service in a patient's chart, and bam, you realize it has both a CPT code and an HCPCS code. Which one wins? Honestly, this is a massive trap on the CPC exam. To pass, you're going to need a mental cheat code to know exactly which book to open and which code to actually report.
The core difference between the two systems is actually pretty straightforward. If CPT is all about what the provider did, the actual service or procedure, HCPCS Level 2 is all about what was supplied. Think durable medical equipment, injectables, prosthetics, the tangible stuff. These are alphanumeric codes, meaning they always start with a single letter from A to V, followed right up by 4 digits. Basically, this is your what was supplied rulebook.
Now, the absolute crucial point here is the payer hierarchy rule. When a service exists in both CPT and HCPCS, the payer's rules dictate the winner. It's their money, right? The CPC exam loves, and I mean literally loves, to test this using Medicare scenarios. For instance, Medicare will very often force you to use a temporary HCPCS G code or Q code instead of a standard CPT code. So, pro tip, if the exam vignette even mentions Medicare, your radar should immediately scan for those G codes.
And that brings us to the two main categories of HCPCS codes, permanent and temporary. For the permanent national codes, those are maintained jointly by CMS and private payers. Then you have temporary national codes. Now, don't let the name fool you. Temporary doesn't mean they're just going to vanish tomorrow. It just means they were set up to meet immediate statutory or operational needs until the permanent codes can get officially sorted out.
Let's lock in some rapid mnemonics for these permanent codes so you can instantly recognize them on exam day. Ready? Think A for ambulance and supplies. Think E for equipment, specifically durable medical equipment. J is for injectable drugs. And L is for limbs and braces, which covers your orthotics and prosthetics. Literally just lock those 4 letters into your brain right now.
All right, moving over to the temporary codes. Well, this is where the exam sets its traps. G codes are for professional services, and like we said, they are heavily tested in Medicare scenarios. K codes are temporary DME items. Q codes are for temporary supplies, like skin substitutes, for example, and C codes are used specifically in outpatient hospital settings. Again, I can't stress this enough. If the test question screams Medicare, always check if a G code is a better fit than your standard CPT code.
Section 1. High-yield modifiers, specifically anatomical and operational.
Look, missing a modifier in HCPCS coding almost always results in an automatic claim denial. So let's start with the anatomical modifiers. These are highly specific. We're talking FA through F9 for fingers, TA through T9 for toes, and E1 through E4 for eyelids. You're also going to see RC, LC, and LD for coronary arteries, and absolutely most importantly, LT and RT for laterality. If the exam scenario mentions a left ankle orthosis, do not forget to append that LT modifier. Laterality matters big time. Next up, we have ambulance and policy modifiers. Now, ambulance codes use these unique 2-letter combinations that indicate the origin and the destination. For example, RH means a trip from a residence to a hospital. Simple enough, right? We also have the KX modifier, which is basically your way of telling the payer, yes, absolutely all the requirements specified in your strict medical policy have been completely met.
Okay, heads up, because here is the ultimate CPC exam trap. Check out the GA and GZ modifiers. Both of these relate to expected denials, but GA means an advance beneficiary notice, or an ABN, is on file and signed by the patient. GZ, on the other hand, means you expect a denial, but you have no ABN on file. Mixing these two up is a classic liability shift error, so you've really got to read those exam prompts carefully.
Section 2, DME-POS, which covers durable medical equipment logic.
So, to officially classify as DME, an item must meet 3 incredibly strict criteria. Number 1, it must withstand repeated use. Number 2, it primarily serves a medical purpose. And number 3, it's generally not useful to a person in the absence of an illness or injury. Basically, a wheelchair fits this perfectly. Your standard comfy living room recliner? Yeah, not so much.
But listen, billing DME isn't just about picking a random E-code and calling it a day. You need rock-solid documentation. You absolutely must have an explicit physician order and a certificate of medical necessity, usually called a CMN. Without this paperwork actually proving medical necessity, that claim is going nowhere fast.
You've also got to let the source documentation drive your coding modifiers here. Are they renting the wheelchair or are they buying it? If it's a rental, you use modifier RR. If they're buying it outright, you use NU for new equipment or UE for used equipment. Always let the vignette dictate your modifier choice.
All right, let's bring this all together into an ultimate, totally screenshot-worthy cheat sheet. We've stripped away all the fluff for you here. Memorize your A's, E's, and J letters. Lock down those NU, RR, GA, and GZ modifiers we just talked about. And remember those 3 strict criteria for DME. If you master just this one table, you are going to snag some serious points on exam day.
That pretty much wraps up our high-level overview, but I want to leave you with a bit of a provocative thought. What if a J-code is based on a 10 milligram dose, but your provider actually gave 150 milligrams in the clinic? How many units do you actually bill? The exam loves to test your math on this. So, tune into this explainer's next installment, Part 94, where we're going to completely master J-code unit conversion math, dive deep into ambulance coding, and tackle vision and hearing. You definitely won't want to miss it. Catch you next time.